So Harry asked me to show a demonstration of the mediastinal cryobiopsy. I wanted to make it a little bit interesting and found one of our older videos of how we used to do, or how we do the transesophageal cryobiopsy. So it's a really short video to catch you guys on the time. So this is how it starts. The first part is we insert the EBUS scope in the esophagus, and we start using the sonographic orientation. The aorta is the key to know where you are at, the aorta and the liver. So the first thing you have to do is know where you're at, because you don't want to upstage a lymph node or upstage a tumor. In this case, it was a patient with a PET-positive lymph node station 8. And the difference between the transbronchial and transesophageal cryobiopsy is you don't have that much vision. So that's why I like to go deep into the stomach fold so that I can see the needle. And what you would do is basically the normal steps. You take the first transesophageal biopsy to get the TBNA, or to get the sample. Usually with the endobronchial method, you can just do one puncture, that's more than enough. With the esophagus, it's a little bit different. You always need a second biopsy to create the way. So now we're doing the so-called arisa polaris method to make the biopsy channel. So I've already given the sample off to the nurse. And if you can see towards the right of the left of the screen, we're doing it under sonographic guidance. We don't have a macroscopic image. We don't rely on seeing the hole that the needle made in order to get the cryo. But looking at the sonographic image, we see exactly where we made the puncture with the needle. And that's the key aspect from this arisa polaris method. And under sonographic guidance, we slowly insert the cryoprobe. It's going to be in about 10 seconds. There we go. Into the lymph node. It's important to always have the cryoprobe at a little bit distal to where the end of the lymph node is, so that you don't freeze through. We activate for about 4 seconds, and we take the biopsy. Usually 2 biopsies are more than enough when you're doing cryo, but you can take more than 2 in order to get more material for NGS. It was a patient with adenocarcinoma in the end, and the biopsy was viable for molecular testing. So my name is Sammy Onyancha. I'm from Germany, and the plan was to have a discussion on how to do mediastinal cryobiopsy. Harry is going to talk about the high-frequency needle knife. I'm just going to talk about the normal needle and why I favor that. Before I start, some conflicts of interest. There's a bunch of names over there. If you're not on the list, you can contact me later so that we can come a conflict of interest. I'm not really going to talk too much about the history of mediastinal cryobiopsy, because we had different talks the entire day. Jürgen Hetzel had a really good talk showing the different papers, showing how the diagnostic yield is. Eric just talked about it. But just to sum it up, and why we do it, we do it because we have larger samples, we have preserved tissue architecture, and of course we have accurate results. Several papers have been published, the largest one being from the Asian-German group from Heidelberg, which has shown that it's a relatively safe technique with a high diagnostic yield. One new paper, Daniela, you were part of it, is a multi-centric European center paper that we got accepted 2 days ago on the topic of lymphoproliferative diseases, where we've seen a high diagnostic yield in lymphoma when doing mediastinal cryobiopsy. So when we're talking about the challenges that you'd have with mediastinal cryobiopsy, you have to think about 3 things: the cost effectiveness, the learning curve, and the reproducibility, or the feasibility. So how much will the procedure cost me? How easy is it to learn? And how can I easily repeat it, and how safe is it? So we've seen different talks, we've heard different things, and mainly the 2 major needles being used are the 22 gauge crown tip needle and the 19 gauge needle. And I know that's one of the arguments that I get why people say we can't do it with the needle because these needles are expensive. But to be honest, using the needle is the cheaper version, because when you use the needle, you only have lower equipment costs. You only need the EBUS scope, which you need either way. You'd need the disposable cryoprobe, and of course the TBNA, which is pretty much standard. With the cautery method, you need a generator, and of course you need the high-frequency needle knives, which are not available in Europe as we speak. So to go into this argument about needles being expensive, I took a little bit of time and made a really small rundown on the needle prices that we have, especially in Germany. So the standard FNA needles are about 100 to 130 euros, depending on where you buy it. The F&B needles, being the ones with the side port, with the shark tip or the crown tip, go for about 140 to 180. When you're going to the larger bore needles, that's when the prices get a little bit higher, so you can hit up to 300 euros. And of course, that's one of the arguments that you have. I can't do it because I don't want to buy a special needle. So what I did last week, I just took the cheapest needle that there is in the market. That's the VisiShot 1 needle from Olympus. It's pretty much a basic F&A needle, because my personal experience, it's not the needle, it's the puncture technique that's important. So I want to call attention to the time. We're starting at 12:51. So right now we're looking at the station 11R. I've found the spot that I want to do. I'm going to adjust the stylet and then take a quick puncture for the F&A. So there's the needle going in. I give off the stylet to my nurse. And here we're about 12:52. So a minute later of just doing TBNA. And this is with an F&A needle. This isn't a TBNB, this isn't a 19 gauge needle, it's a 21 normal F&A needle. But using the Arisa Polaris method, I'm able to get the cryoprobe in and still do the biopsy. So the argument about the needle price being a hindrance isn't a valid argument for me, because the puncture technique is the most important part. So the next part is the learning curve. The thing about using a needle-based technique is you don't have to teach yourself newer technologies. You already do the TBNA as normal, so you just have to add cryo on it. The advantage of the needle-based method is that there is a paper, there's a standard guide. I was happy to be a part of this paper with Miguel Ariza, which teaches this 4-step Arisa Polaris method that I've mentioned before. How you make the canal, how you break the mucosa of the position that you're trying to get into, how you break the lymph node capsule. So this is a very reproducible technique. In my hospital, we have very advanced equipment. I know we've heard talks about robotics, but what I use, it's called a hands-free voice-activated bronchoscopy. It's very new, it's reusable, but basically that's just me standing next to my fellow barking orders when she's doing bronchoscopy. So this is my hands-free bronchoscopy. So this is one of our fellows who is training in pulmonology. She has about experience of 30 EBUS interventions with me, not doing them herself. But here she's learning doing how she can do the rigid bronchoscopy, and she's doing now the EBUS with the Arisa Polaris method. Unfortunately, you can't see the time, but it's the similar situation to me, in that after doing the biopsy, in about a minute or even less, she will be able to get the cryoprobe into the lymph node. And we're talking about someone who hasn't seen or hasn't performed 50 EBUS interventions on her own. So I'm going to highlight this again. We're not using the macroscopic image. We're using the sonographic image. That's the most important part about it. So I'm just telling her to move the EBUS scope, because I saw where she broke the capsule. That's around about here. And again, under no macroscopic imaging, she manages to slowly insert the cryoprobe into the lymph node with ease, without any resistance. And this is, like I said, in about a minute of work, and for a beginner. So we secure the cryoprobe as we always do. We like to leave the top open and hold the bronchoscope at the bottom so that we have a control when we're pulling out the probe. And as you can see, she has a very good sample. So the method is also advantageous in that you can teach it to even junior doctors. So when we're talking about the feasibility and reproducibility, the safety profile is very good. When you look at the literature out there, the only cases of complications were pneumothorax, were the cases with the high-frequency needle knife. We only have one major case of bleeding when you're using the needle. But this case, I think it's more about where the colleague froze and not the needle itself. I already showed you the transesophageal cryobiopsy. We wrote a paper last year about it with our first 30 cases. The follow-up paper with 80 cases is coming out this year. So there's been a lot of data there showing that just using the needle is safe compared to using the high-frequency needle knife. And to demonstrate this, I'm going to talk about a patient that I had last week. It was a patient who was referred to us for EBUS, a patient with bilateral pleural effusion, mediastinal lymphadenopathy. She had necrotic lymph nodes, so we were planning to do an EBUS cryobiopsy. Unfortunately, the patient crashed out before we could start with the EBUS, or before we could get her into the endoscopy room. She ended up getting intubated, and this is our ICU. So that's why you see intensive station. So seeing as the patient is intubated with an FeO2 from 80%, we still had to make the decision, is this a patient who we want to keep on the ICU? Are we going to do a tracheotomy? Are we going to go through the whole process of ICU medication? Or are we going to do an EBUS? So this is me with my nurse rolling up into the ICU station. As you can see, we have different medical applications. She's intubated, and this is me just doing the EBUS. And like I said, we don't have to bring a lot of equipment with us. All we need is a needle, a little bit of patience, and of course, an EBUS system. So again, notice the time. It says 5:15, but it was 3:15. So this is basically how we do it. We create the tract with a needle. You can see some ultrasound traces of the tract here, the black line. And then I'm going to hand out the needle, and then we're going to perform 3 cryobiopsies. We're able to do 3 cryobiopsies in about 2 minutes, and it ended up confirming the diagnosis of small cell lung cancer, which was for us important because we could end up deciding how we can treat the patient in the end. We didn't want to prolong the ICU station, so we started to do a palliation. In this case, it would be difficult for me to use cautery system because the patient had a high FeO2. So with the high FeO2, I would not be able to use a cautery system, but with the normal EBUS or the normal TBNA method, you can do it at any time. Just going to skip. In our hospital, we don't have rows. We have, I call it nose, so it's nurse on-site evaluation. So I take a puncture and the nurse tells me it's a good biopsy or not, and that is the advantage of the needle method. I'm having a complementary system to the TBNA method, meaning I can choose to do the cryobiopsy or not. I do the TBNA, the nurse says that the sample is good enough, then I'll stop at that. When she says it's not good enough, I'll do the cryobiopsy. If I ended up using a cautery system, I have to do the cryobiopsy because the cautery knife does not give me a biopsy. So this is also a way that the needle-based method becomes an efficient tool because you don't have to always use cryobiopsy. You can decide whether or not to have it as a step up or leave it at that. And with that, I just want to summarize my talk. I'm in favor of the needle because it has a high safety profile, it's cost-effective, and also has a very good learning curve. Thank you.